Welcome to this Mtech Access webinar. At Mtech Access, we provide health economics and outcomes research and market access services from strategy through to implementation. Our unique NHS relationships guide and validate everything we do in the UK. We work with over 80 NHS Associates to bring our pharmaceutical and medtech clients authentic insights into the NHS. We can help you answer key questions related to the NHS, from how to communicate with integrated care systems, places and primary care networks, to how to capture pathways of care. Get in touch today to discuss your market access goals. First though, I hope you enjoy the webinar. Good afternoon everybody and welcome to this Mtech Access webinar on policy, GP contract and primary care. My name's Karen Cooper and I'm a senior consultant in the NHS Insight and Interaction team at Mtech Access, and it's my pleasure to extend a warm welcome to our speakers for today's session and participants that have joined today. For those of us that don't know us well, Mtech Access is a specialist market access consultancy and we provide strategy and solutions to help pharma and medtech companies bring interventions to market. And we also work as a collaborative partner to the NHS. So today we have Zafran Azam, Jack Wagstaff and Neil Forster, who are experts in their field, no pressure, to share their wealth of knowledge and experience on primary care, the GP contract and network DES, and the NHS priorities and operational planning guidance. Their insights are sure to be thought-provoking and provide valued perspectives that will benefit us all. So I'm thrilled so many of you could join us today, and let's get right into it. And I'm going to come over to our panel and ask you to introduce yourselves. So if you could let us know what your role is and where you work, please. So I'll come to Neil first and then to Zafran.
Hi there. Hi, Karen. Hi, panelists, and welcome everyone. I'm Neil Forster, GP in Northumberland, GP partner for 20 years in the same practice. I've also got interest in occupational medicine and also clinical director of our federation up in Northumberland. So, yeah, I'm interested in market access, strategic consultancy, and also thinking through some of the problems that face our industries. That's me.
Perfect. And Zafran?
Yeah, hi, my name is Zafran Azam. I'm head of medicine optimization and delivery at Derby City Place. I'm also lead on a lot of programs like respiratory self-care, to name but a few. I'm also a qualified coach and mentor, and I'm very interested in talent management, workforce development, and organised system change as well as part of my kind of portfolio of working.
Okay, and last but not least, Jack.
Hi, really good to be here this afternoon. I'm hoping to get the recording of Karen's billing to play to my wife at home, so we'll see if I can get that at the end. But it's really good to be with everyone. I'm Jack Wagstaff. I'm the chief officer for a partnership of 11 organisations in Northwest Surrey, just under Heathrow Airport, across primary care, community, mental health, acute care. I'm an exec director for Surrey Heartlands ICB, covering sustainability and financial recovery, and the acting chief delivery officer for Ashford and St Peter's Hospitals on our new elective centre here. So if you hear any drilling, that's apologies. I think we're building something just over that wall.
Thank you. So as you can see, we've got a selection of perspectives from all different parts of the system. So I think this is going to be really interesting. So let's start strategically. So let's start by talking about the priorities and operational planning guidance. So we know that normally this is published in December, so to give people like yourselves a chance to plan for the next year. This year it arrived one working day before the new financial year. So I'd be interested, because everyone was waiting, constantly waiting for it to be published. Finally it was published. It'd be interesting to understand your thoughts on the impact that had around your planning for this year, or whether you just carried on regardless. So I'll come to Jack on that first.
Yeah, of course, I was particularly interested around this year. I mean, I think we had a lot of informal sort of assurances that there wasn't going to be any drastic changes in the planning guidance. So we could make quite sensible planning assumptions based on based on the known factors, and I don't think there was anything in there that was hugely surprising for organisations and boards up and down the country. I think probably the biggest challenge in this planning round really is the quite significant gulf between the operational planning requirements in terms of what the NHS and health systems and public bodies are asked to do and to deliver, and the financial planning framework, which is very much about reducing costs, taking cost control and constraint to resources and workforce and other elements, and I think it's that sort of often what feels like quite contradictory policy directions, which I think are really the issues that organisations are wrestling with in terms of what do you prioritise, where do you really want to see gains, and what are you probably gonna not do or put on the back burner as a result of those contradictions. I think is probably the real key challenge in the planning round this year.
Okay, thank you. And Zafran, what about yourself?
So for us, we'd already had since July 23 the Making More of Medicine's medicine optimization kind of opportunities document come out. We'd also had the National Medicines Optimization opportunities came out in roughly around about August 23. So we already got a planning as to what we were doing for 23-24, and in that document we already got an idea of what was going for 24-25. We also understand the 4 key areas that all ICBs are working towards. So I think, just like Jack said, for us it was more of the same, understanding what the ask is, and having already got a plan for that in year, and having a 5-year plan as well, making sure there's nothing there that was an outlier that we need to then pick up as a mandatory function or a core function as an ICB. So for us it was, we know what's coming, and there's that Johari's window of unknown, and making sure there's nothing there that was a bit of a surprise. And I dare say I don't think much of it was. I think a lot of it is. It's around the financials, it's around the workforce challenges, and it's also around the actual pressures, and it's how we're trying to unpick all that in that kind of very complex human adaptive systems that we exist in. So again, it's been clear for us from quite early on last year as to what our kind of priorities were as a system organisation. But then also it's compounded by ensuring that that's aligned to what then comes along, and so you do get slight policy change, and therefore that impacts the shift in terms of the overall system. But the 5-year plan is the 5-year plan, and that's what we're trying to work towards, I would say.
Okay, thanks, Zafran.
You're welcome.
So Neil, for you, how important is the operational planning guidance in your role?
It's difficult because there's so many other factors that are affecting primary care at the moment that we didn't see. We weren't really waiting for this document to come from on a practice level, because there's so many other issues and opportunities to address before that. The 2 weeks, an appointment within 2 weeks ask has already been mentioned prior to this coming out, and then the on the same day type access was already there as well. I think most practices are working to a on the day demand type model, following on from what the COVID situation led us into, really. So it really changed. So yeah, it's interesting how little of it is actually about, in the operational plan, is about primary care, because the vast majority of NHS activity happens in primary care. There's 1.3 million appointments a day in GP practices. So it's there's very, very little of that reflected in the document. But it isn't, that's not really our major focus. Our major focus was probably the GP contract and how that was going to be negotiated and then came out. So that's probably a more important document for us rather than the operational plan. Yeah.
Okay. So already we can see the difference, so Zafran's obviously focusing on the medicines optimization opportunities document, you're focusing on the GP contract, and the planning guidance is, is more relevant at Jack's strategic point of view.
Yeah,
although
exactly. It's a much higher level of, like Jack is involved in, it's a much higher level of strategy than just practices.
Okay.
I was also going to say, Karen, sorry.
Yep.
I was also going to say, we, for example, have the ITMO, the Integrated Pharmacy Medicine Optimization, which is wider than just RICB kind of medicines. It's about the kind of workforce delivery in terms of pharmacy. So there are like Neil's already alluded to, there's different documents that people are working throughout the system, and it's then being able to unpick that. But there is a wider overarching strategy, if that makes any sense. So where people will focus on one arm of that wider strategy and plan, that plan is being pulled together centrally. So there is an overarching system-wide approach in how we do things, and it's the fact that you can't do everything. So it's having experts in key areas to be able to deliver that really well. And I think the whole point of the plan is to ensure that those stakeholders and those partners are actually heard, brought to the table, and actually they help to bring the solutions. So it's not, so the whole point of documents is great, and I get that completely, but there still needs to be co-creation, and that's what all these documents are saying. They're not saying that shouldn't be done. That absolutely has to be done as an integral part in order to achieve any successes, for our patients and outcomes.
I think it's a really challenging time to release planning guidance and health policy at the moment as well. It's obviously heavily anticipated to be an election year, so there'll be political pressure to promise everything in terms of waiting list reduction and speed of access to primary care and availability of services and developments across all the bits, and being friendly to business and provision across different sectors, and then at the same time a financial growth trajectory. I think we've just passed 43% of GDP being spent on health this last year, and that's grown by about sort of 5 or 6% in the last 3 or 4 years. So you've got a sort of out of control financial trajectory for the state overall, and then a political dynamic that wants to promise everything to the public this year, and that creates a real challenge for people. And I think, as Neil and Zafran have described, the art is in really understanding what are the key priorities that are going to give you value, and where do you really want to focus your time and your limited resources to deliver the best care and deliver the best organisational results. As you have to be really quite discerning when you're looking at a document that has hundreds of deliverables in it, and really understand the motivation behind some of that, I think.
So thinking about our audience that are listening in today, and looking through, we'll move on to the GP contract in a minute, Neil, and and the DES and everything, but just thinking about staying with the planning guidance, reading through it, there's only 5 references to medicine within there. There are 9 references to prevention, so the one balances out the other, but there's only 5 references to medicines as such. Obviously there is an objective around medicines, but there's 32 references around productivity, 37 references around capacity, recovery is mentioned 18 times, and medicines is only mentioned 5 times, and every single mention is talking about cost savings. Now, obviously, we're recognising exactly that around, we're in a really cash-strapped environment, and a lot of money is spent on medicines, but the fact that it's only mentioned 5 times, I'm curious what your views are on that. Is it that the value of medicines in the NHS is undervalued, or is there another reason? So what are your thoughts on that? I'll come to you, Zafran, first.
Thank you for that, Karen. Yeah, so medicines are used in almost all clinical pathways, we know that. And the spends on medicines, I believe it consumes the second largest share of the NHS budget in England. So as I've alluded to, even though it may have been mentioned 5 times, there will be pathways in clinical services that it will have an impact on. So it literally touches everything. So I don't think you need to overemphasize that there's a use of medicines. It's a bit like, overemphasizing the use of clinicians. Without them, we just can't work, we can't operate. So there's always that kind of core assumption. And then beyond that, this national planning document, you've also got the documents that I've alluded to previously around the national medicine optimization opportunities, which then goes into detail for each of the ICBs. So I'm not too concerned about the fact that there's not a huge mention of medicines per se. I think that's already a caveat and already given, if that makes any sense. And I think when you talk about cost savings and efficiencies within our kind of system, and a lot of the national papers that I've read and looked at, it's around best value. So it's not just about cost savings and efficiencies. It's also about how we do procurement. It's about how we do things and doing it once, doing it right. It's also about being mindful about the impact that may have in terms of shaping other services. So it's being a bit more mindful and having a more integrated approach. And it's also, it does talk about efficiency savings, and but it also talks about clinical safety as well. So, so for example, polypharmacy is a huge area. And a lot of the time you maybe argue that deprescribing actually doesn't save you a huge amount of money because of the amount of intervention required, the clinical intervention required. If you speak to clinicians about when they're deprescribing someone, for example, who's been on long-term benzodiazepines, for the saving you get in money, for the reduction, for the time put in, there's no value in terms of cost efficiencies there in terms of medicines. But from a clinical and holistic point of view, is it the right thing to do? Absolutely. So it's about patient care, and it's about shifting and ensuring you maximize savings, but without the detriment to the patient itself. And that's very mindful about how we and our approach is. So we don't do things just because it's going to save us money without understanding what that impact could be for our patients, for our key stakeholders, for our clinicians, for our consultants, the wider impact. And sometimes there's future planning as well, where you may be getting things coming off patent, and there may be a long-term impact by doing something now because we're not thinking ahead. So there has to be that kind of regional brain and regional thinking. So I'm not really too concerned about the fact that medicines aren't mentioned too much, because we know that they're high spend anyway, and we know they're part of clinical pathways and services. And I'm not also too concerned, and I am, in terms of just about cost saving, because we get it, because it's not just about cost saving for us. So I think that's the difference. If the only thing that we thought was important was just saving money and not thinking about the patient and the system, then I think most of us probably wouldn't work for the NHS. That's not how it works really on the ground. And because we're all part of this wonderful organisation and system, and it's part of the fabric of our country, to be honest. So we all want to make a difference, and we all want to try and leave it in a better place than where we came. So as a result of that, we're trying to do the best that we can. And money is going to be important because money is tight. It's like being in a very thrifty household. It's how can we do things better, knowing that we haven't got enough resource, or making that resource stretch. And that's what we're trying to do.
Yeah.
So I hope that explains that a bit.
Absolutely. Absolutely. Yeah. So you were nodding, Neil.
Because it's a real interesting change in how medicine optimization has morphed over the 20 years I've been involved in practice. And I think medicine optimization has we think of it as a scary cost-saving exercise, but potential for pharmaceutical companies to maximize their product share, their market share with their products. There's a lot of opportunity in meds optimization. It used to be that we'd get a diktat that we'd change to the cheapest generic that was around without any sort of cost analysis of what that's going to mean to primary care in terms of the cost to change both in patient terms and destabilizing their care, but also in practices in employing them staff to do 2 or 3 different follow-up appointments. But I think now medicine optimization, now we've got the pharmacist teams involved, it's much more successful, and it's much more focused on system benefit and patient benefit, rather than being just a true cost exercise, an acquisition cost exercise, which is, so there are opportunities in medicine optimization. The other point I wanted to raise was about the interpretation of the operational plan. One thing is the massive opportunity is diagnostics. So there's a massive push to get early diagnostics done within 6 weeks, I think, 95% by next year. So there's a lot of point of care testing that could be implemented. There's a lot of opportunity there for companies to work with ICBs, PCNs, to try and achieve that target. So that's not something to be missed, because that's a whole sort of new area of near patient testing.
Yeah. And if I could add to that, sorry, Karen, I'm just going to say you're absolutely right, Neil. And then you've also got the health innovation networks, which were previously the allied health science networks, and the NHS mandate for them to go and work with private industry, third-party providers to look at how they can use innovation, medtech, to actually bring that into the NHS at a pace and scale. So we're not saying do a pilot here and that's it. We said do a pilot here and scale that up. So there is lots of opportunities, and I think the NHS has recognised that we need more of that, more the kind of the innovation, that critical thinking. So you're right, Neil. There is a lot more kind of opportunity in terms of working dynamics and what that can look like in the future, and even now.
Brilliant. Have you got any thoughts around that, Jack, before I move off?
I wasn't surprised that it wasn't hugely mentioned in the plan guides, and I think it's really interesting factor of medicines in terms of how it's sort of managed strategically. I think you rarely have discussions about management medicines at a board level across any of the organisations I've worked with. It's very much the domain, in my experience, of the chief pharmacist, medicine officer, the professional strand that goes through that, and that is managed as a function of organisations, but rarely is the sort of strategic direction of medicine sort of debated at an organisational level. I think that's probably fair enough. That's not saying that's right or wrong. It's just a factor. I think there is inevitably a financial dimension to it, and organisations and systems are put under a lot of pressure to be unit efficient, as essentially from a pricing point of view. But we've also had, at least in recent years, massive exposure to national supply chain vulnerabilities and international supply chain vulnerabilities that's really hit organisations across the board quite hard. So mitigating those sorts of pressures is really important. I think there's some really interesting thinking around the how we build wider value propositions for medicines and devices across the board. So at the moment, the debate is too often overly simplistic between, this cost is lower than that cost, whereas actually we've been able to do things differently around actually that one requires X less of district nurse time to administer in the community, and therefore it releases 15% of workforce capacity, and therefore the economic gain is to the system is X and Y. Or on the surgical side, there's different sorts of commercial partnerships that I think we can be exploring that perhaps offer exclusivity of product, but then a different partnership around training or investment in facilities or things like that. So I think I think we need to slightly move away from just competing on units of product, and then more about strategic partnerships with organisations that are bit more holistic in terms of the knowledge and impact on the healthcare business overall, if you like.
Yep. Thank you. I'm just thinking, Zafran, you've mentioned a couple of times. If I come to you, Neil, you've mentioned the medicines optimisation opportunities, the 16 national priorities. Could you talk a little bit about that? Because we are asked quite a lot in terms of how are policies like that decided on. So how do you decide which 5 you're going to implement, and how is that? How's it decided, and how's it communicated down through the system? So how's it come from your level, Zafran, and what impact does it have on you, Neil? What level of influence do you have? I'll come to you, Zafran.
Yeah, sure, no problem, Karen. So obviously there's 16 areas of opportunity. They're listed out in the national document, and then based on that, you then obviously we take that back to your kind of SRO, chief pharmacist. You'd use data, you'd use your prescribing advisors, you'd use your clinical leads, you'd lead your lead GPs, and you'd work through what the key priorities are, where there are maybe potential savings over kind of key areas, or whether there's for example, something that has a real clinical kind of area that you think actually that's a safety issue, like for example high opioid prescribing, and how we can tackle that. So nothing is really done in isolation. It's done through that kind of collaborative working, that kind of critical thinking with key stakeholders, and then nationally we need to develop a plan to deliver at least 5 of those national medicine optimization opportunities, and we have to do that. So we have to where it will improve local population health outcomes, and we need to make sure that these align to being that they complement the local medicines optimization priorities. So we don't want to do something that actually has a negative or adverse impact on what we're doing locally. So first of all, there's a whole issue around alignment, and then there's getting agreement. And then once that's agreement, then it's making sure that we've got the kind of the policy decision making right. So obviously there'll be like an area prescribing committee, or where that will go and be signed off and ratified, and where you've looked at other services like pharmacy, dentistry, and optometry to make sure that we're not doing something that's going to impact them and be harmful to them in terms of those kind of contractors as well. And then it's making sure that there's co-production wherever possible. So it's and that's where you need the public and the patient's voice as well as the key stakeholders. And so then there's a bit about the learning, like I said before, about our do once approach. And that's what Neil was alluding to. We don't want to be doing stuff just for the sake of doing it and then having to do unnecessary duplication or having to add more resource in downstream. So just because we might not be doing that or somebody else is doing it doesn't mean that's a good use of anybody's resource. So that's kind of how we kind of plan it and manage it. And yes, where there are kind of key metrics like, as Jack has talked about, right, in terms of, for example, unit price and cost savings, then obviously we'll attribute that. But some of it might be around actually, well, we want to reduce the antimicrobial resistance, so we're looking at antimicrobial prescribing and reducing that down to 5-day working. Or we might be high in opioid prescribing in certain areas, so we look at new ways of working, innovation, bringing in technology, helping patients in different ways, and that holistic approach to helping to reduce that. Or it might be, for example, looking at antidepressant prescribing and how we'd want to work with wider holistic practitioners, where we might want to work with social prescribers within place and PCN practices, and what that would look like. But you can't do any of that. You can't forge it just sat in a room somewhere on your own. You've got to have people involved and engaged at all levels. And then, and the whole point of co-creation is that then, or co-production is that then you've got key people who've got ownership of that. So it's a real kind of system change. That's how you would then get down to those 5 kind of key priorities that they then got very clear for the year. So then people understand the why, they understand the how and the what as well, because how we're going to do it and what that means for them, and then everyone's tackling it from that kind of whole issue. So that's why planning now is a lot more, as Neil was saying before, it's not just about a gung-ho approach and going doing something. There's got to be planning and there's got to be some real engagement, and then there's got to be some clear metrics. And for us, for those key national 5 indicators that we may take on, we've then got to have a confirm and challenge with the regional kind of NHS England to ensure that we're doing that as a system. But there's also something about shared learning across a region. So what's our neighbours doing? What are they doing? What's worked well? What hasn't? So it's sharing that best practice. So it's being more open and transparent about why you're doing what you're doing. There's no kind of backdoor kind of jobs being done or cloak and dagger. It has to be very open. And I think, as Neil was alluding to, and we have to be very honest about that. And that's honest and open conversations. Hope that explains a bit of it.
Yeah, absolutely. I'll come to Neil because I mean that sounds ideal, Zafran. If that's how it's being decided, is that your experience, Neil?
Yeah, well, that's my experience anyway. That's what we're trying to do. So before I get shut down, that is what we're trying to do. Absolutely, that's the aspiration.
Yeah, absolutely.
I think that's the best practice, and I think that you have to work as a team, because the way that this is deployed is through other parties. And you have to get everyone on board with why you're making that change. Yeah. If why you're making the change is just a cost saving, and that cost is never seen, the team that's doing expending their resource actually never see those cost savings. So that's one big mistake that people make, is that the actual prescribing budget affects general practice funding, which it doesn't. So if I prescribe something very expensive, it doesn't mean I have less money. If I prescribe something very cheap, it doesn't mean I can say I get to keep that money, nor does it mean that money actually comes back into primary care. And so it's a really hard thing to motivate. So previously, it was just a dictation that you wanted to change. You had a target to get everyone onto certain particular medication, and it wasn't always scientifically clear as to how they'd chosen that medication for people to change to. And there wasn't a good economic argument if people had a clinically safe control of, let's say, the blood pressure. Why would you want to destabilize that situation? It's a long-term treatment. But I don't think that's happened. We haven't had as many switches over the past 5 or 10 years. We used to switch every year. There'd be something else to change to because it became off patent. Drugs are obviously terrible whilst they're on patent, and as soon as they're generic, they're the best thing ever. And so we saw a massive increase in particularly lipid management medication or antiplatelet stuff. It was suddenly the best thing ever once it was cheap. And that's probably down to cost modelling and economics, but I'm sure there's less subtle reasons why that might happen. But yeah, I think working as a team, this is a team project. The NHS needs to work more together so that the savings that are released from this come back into support practices, support pharmacists, and support the wider team. Medicines are a massive cost, a massive part of it, but they're a massive necessity as well. You know, there's not we take it for granted that there's the solution to somebody's problem, and often there is, and that is as a result of the money spent through pharmaceutical research. So yeah, I don't think I have anything much more about that. I mean, it's to make a difference to that, you would need to have some input into the advisory boards for the prescribing guidelines and things. But I'd imagine that is, Zafran knows better about that, how they make the choice about what is the optimum product range to choose for certain things.
Yeah. Just Jack, I don't want to not include you in that, because I know you were saying that obviously these sort of, the discussions around medicines, things fall to the likes of Zafran and Neil. Do medicines conversations cross your desk? Is that something you ever talk about?
I think it. So in terms of how the business cycle works. So I would normally work with our chief pharmacist in terms of setting the annual plan. Look at the budgets, look at the areas where we're gaining efficiencies, the new investment areas we need to make if there are technology appraisals coming down or other stuff. So there's definitely that initial business planning bit. I think we do get involved. So certainly I get involved with our chief pharmacist on some of the elements that Neil talks about, which I think are really important around how you develop a better model to drive efficiency and improvement in practice that gets a share of benefit back into the teams that are doing it. I think that's really important, because otherwise you are just bludgeoning people every year to say, oh, spend less, be more productive, do more work, for less resource, and so on and so on. So that how we develop that model of gain share is something that we would definitely be sort of worked on throughout the organisation, and then there'll only be really specific high risk or high gain areas would normally be more addressed at a board level. So recently some of the biosimilar switching in more in acute care has been very high value, clinically contentious in some areas, legally contentious in some areas, and there's quite a variability in pace of uptake across hospitals, even within a relatively small geography. So those sorts of things would sort of make it to board level, and we'd have debate about that, or intervene with different trusts and so on, or need to bring different clinical teams together to debate the merits of things like that. So it's when it gets to a certain threshold really, and it's one particular problem. Diabetic technology and new monitoring and stuff coming through there again is a massive investment area. And again, it's an area where the centre may make a decision to say, oh, everybody should be entitled to this, and then quietly they'll say to you, well, there's no much money to pay for that. So be prepared to absorb that massive cost pressure in that year, and then you have to find a way of doing that within, and which means other stuff will lose out. So in some of those really big trade-off conversations, does it sort of get to organisational level, I think.
Okay, that's really interesting. Okay,
I was also going to say, sorry, Karen, I was also going to say, apologies. I was also going to say there's something around population health management as well, health inequalities. So there's always, when you look at prescribing, you look at what's not being prescribed or what's not being picked up. So for example, for us, it's hypertension case finding, and a lot of that kind of work you can't do on your own. So you've got the public health consultants, the experts, you've got data analysts, you've got all that integral telling you where the issues are. But then you're also going to need private providers, third-party providers, PCNs, practices to work together, the voluntary sector, local authorities, to help you to identify those and treat those patients. So there is something about, yes, prescribing is important, but and there is always people talk about de-prescribing, but there's lots of areas, as Neil's alluded to, that actually we need to upskill to be more around secondary prevention as well. So, and also initial diagnosis. So we're seeing a lot more of that work coming through as well now.
Yeah, Zafran, that's a really important thing, because that's an open market, really, in sort of third parties being involved in providing or detection services, or looking at providing focused long-term condition management. There's a whole lot of non-pharmaceuticals, but they're actually a service that that teams would be able to provide. It's a business opportunity, isn't it?
Yeah, and not only that, if you think about that on a wider scale, a lot of that kind of case finding stuff, etc., might be coming through pharmacies, for example, where they're helping to find those patients. Well, how could they do it? Or because they've also got issues with resources, how could they use different technology? What could that look like? So some of this work, I mean, a lot of this work is actually quite exciting, because it's about health innovation. It's about using different things, different models. It's about trying and testing, and not being afraid of trying something and they're not working, but as long as you learn something from that and you share that across the system. So and you do start getting some wonderful pockets of experience of how that works, and very quickly that's become adapted.
That is, you hit the nail on the head there. Trying and accepting failing, because that is something that in the clinical world, that's a big no, isn't it?
Yeah.
Trying and accepting failing. So it's a whole mind shift to entrepreneurialism, and actually looking at opportunities and making a change. If it doesn't work, switch to a different opportunity. But there are a lot of opportunities in that market.
Yeah, there's lots of areas of work that Zafran just mentioned that aren't overtly badged as medicine strategically or in documents you read, but actually are quite, the medication interventions are quite critical in the preventative agenda, Karen, that you mentioned across the board. That has to be highly targeted, a real focus on detection, a real focus on some of the data and intelligence infrastructure that goes around there, but they are often medication based solutions, and in fact I think that's the health service, I think, has got to really target its role much more specifically on some of those things. So I think my personal view is that we're a bit too woolly in terms of that we want to do prevention or address health inequality, and when you look at health inequality, that's so I'm sitting in Ashford Hospital, which is under Heathrow Airport, and if I drive 20 minutes that way, by the time I got there, the life expectancy would have gone up for every 1.5 minutes I've been in the car by a year. The people live that far down the road live 14 years longer than the people in this community. But there's I could throw the entire health spend at that problem in this area, and I wouldn't make a dent in it, because the driver of that is the economic prosperity of the area around Heathrow Airport compared to a leafy, affluent town down the road. So if where we're talking about intervening in health inequalities, we have to be really specific in terms of the samples of the communities we want to influence, and what are the factors we're trying to move, because at the end of the day, most of your health outcome is not determined by your healthcare. It's determined by your standard of living, and the quality of your housing, and the quality of your education, and the amount you take home every month, and all the rest of it. So we have to be really quite specific and quite targeted in how we build those interventions from a health inequality point of view.
That's really
I would say, sorry.
Yeah.
Sorry, thanks, Karen. And I would say that's where population health management really helps you do that, because you've got data set upon data set that allows you to look at it. So, for example, one area of learning for us has been that there's an assumption that because you're in very deprived areas, you don't have high opioid prescribing, deprivation, lack of opportunity, etc. But then you get pockets of high opioid use in very affluent areas as well. So what's going on there? So it's not just, so the data allows you to map out the areas that you need to work in. And sometimes the areas that you think there's an assumption generally that would be aren't always the only areas. So data is really important and really powerful. And the reason why I've interjected, Jack, so my apologies, is not everyone's got a handle on data. We haven't all got a handle on data. So the reality of it is there's some real opportunity there around how data is really captured, managed, and what that may look like across a landscape. So that's really powerful.
Completely agree with that. The variability in the intelligence landscape is massive really, and again that's an area I think we're, in terms of working with industry in areas of mutual benefit, where actually you can sometimes access expertise and infrastructure that is a lot better than the public sector can access.
And then
there's a good opportunity there. Go on.
Just getting a bit excited and above my station there. I was just going to say, you all heard of the Rs funding. Well, as part of the Rs funding now, you can actually fund for data analysts. So again, where would they come from? Where would they have the expertise from? Who could bring them in? How could they co-create, co-locate, co-production? What could that look like? So there's a real kind of opportunity as PCNs really develop around their resourcing and what they've got. There's also opportunity for them to actually then take and shape that kind of working as well. So there's lots of opportunities out there that people probably don't think about when they think about generally in data, population health management, the public health policy, et cetera, et cetera. It's huge.
That's really interesting, Jack, when you're talking about health inequalities, and it's conversations we have quite a lot. And it's quite interesting because when objectives are set around certain areas, they're really specific, and then in others it says things like address health inequalities and deliver the core 20+5 approach. So I'd be really interested, have any of you got any examples of initiatives within your area where you're delivering, in inverted commas, delivering the core 20+5 approach?
Yeah, Karen, we've got an example from our PCN, well up north. We're obviously Northumberland's a very rural sort of area, a lot of farmers, and we know that they're ones that don't access services very often. And so we've got a local initiative run through our staff funding that is based in the livestock markets and does outreach work there, and does CVD assessments like an NHS health tech type offer. And that's had great uptake and been really welcomed by the community.
Brilliant. Yeah. Anybody else got any?
Yeah, I think this is one of the areas we really leverage our partnerships across the different organisations. So we probably there's two sorts of types of project we would have. We would have ones that are highly medical in nature. So we have ones that are quite zoomed in on, actually we know there's a real higher prevalence of CVD or AF or hypertension in that area, and we need to really focus in on equalising that particular health outcome and getting people detected and onto the right treatment, because we know that will save X number of lives in the over the next 5 years, and so there's areas of communities that we've been able to use data intelligence to target very much like that. The ones that I think was a little more interested in some ways are where we've tried to use NHS capital development quite differently. So one of our areas, we're looking at building a new health centre and getting rid of some of our old falling down GP practices and using that to build a new facility, but in a place that then has a leisure centre attached to it and creates footfall for business and regenerates a high street that then regenerates an area and creates more wealth in that area that over time will equalise outcomes for a community. And we have quite close partnerships with our boroughs, borough council authorities that are part of our alliance that now enables us to do that. So and I almost think that's probably where the gain is on health inequalities. It's that's about regenerating towns, really, is where the gain is in that. I think, as I say, the health sector's role is probably really a lot smaller, and is in focusing on those areas where you've got health access inequality more than a health outcome inequality, if you like. So we have two strands of projects on that, and they're both quite measurable in their results, really.
Yeah, brilliant.
Okay. So I was going to say, so we had one with the hypertension case finding where we wanted to work within quite a deprived inner city area, and it was working with the GPs and pharmacies, and we realised that they were, as most of primary care is, really up to the hill in terms of resourcing. So they came across with a really great idea of using the voluntary sector by training them up and mobilizing them to go out to communities and to actually help find those hypertension cases, those patients. And so that was a very small pilot, but exceptionally successful, and that's now been rolled out. So there is, when you turn things on its head and you get partnerships involved and you get different ideas and creativity, it's amazing what you can actually achieve. And so then we've actually trained an army of people to become, volunteers to go out and to scope and to find those patients. So then the community almost takes ownership for those health inequalities and then tries to move forward as to how they can do that better. And that's then has a spin-off of walking groups, people going for, cups of teas. There's people now looking to how they can lose weight. There's a whole campaign around, staying healthy, and that's been taken over by the voluntary sector, which says it has an impact on local communities. So I think, there's different ways of working, but it can definitely have an impact.
I think we're pursuing a lot more devolution as well now, Karen, and I think that's so increasingly we're looking at an area and thinking, actually, what do we do in that town? What's the population profile of that town? What's the need in a given area? And then we're devolving, the budgetary aspects, team composition, whatever it is, and clinical leaders in that town then shape the team for that neighbourhood, and it allows you to be much more targeted. So if you've got a higher prevalence of mental health and you need mental health practitioners rather than heart failure specialist nurses, you're able to modify that team and tailor a professional skill mix that's a lot more specific to a community. And I think increasingly those sort of neighbourhood footprints are going to be the building block that we do our first sort of round of planning on, really.
Yeah, there's a large drive to it. Oh yeah, sorry.
If I could just be controversially commercial, there's a lot of opportunity in health inequalities. In terms of marketing, brand awareness, brands could support these initiatives. There's potential for health service awards. There's all sorts of things that are marketing opportunities with health inequalities, because it's such a well-loved area and it's such a priority. And you need to really think, well, it's not direct marketing, but there's a lot of reputational gain from helping these projects. That's just my little commercial thing there.
I like that. Commercially controversial. Carry on. That's what we like to hear. We'll stay with you, Neil. Let's go on to the GP. We've got about 15 minutes left. Let's go on to the GP contract and the network contract, Des. So obviously we know, BMA is publishing figures around 2/3 of GP practices are expressing concern about financial stability and longevity. It'd be really interesting to hear what it's like out there in terms of, you've obviously had the 2% pay.
Yeah.
Say price, but and there's different elements that have come across in the PCN Des in terms of some of the QOF indicators being financially protected and IIF reducing. What's that looking like in general practice?
It's looking terrible, really, to be honest, Karen. I don't want to be all doom and gloom, because this is opportunity. So there's blood on the streets. It's an opportunity, and the actual funding has gone from per capita patient was 152 in 2016 pounds per year per patient to 164 pounds per patient per year in 2022. So there's not a lot of increase for such a long time, and we all know inflationary costs, staff pressures are a real big concern, both in terms of the unaffordability of pay increases, that aren't reflected in the contract, and also the workload. I suppose it's maxed out. The headlines are that a lot of funding is coming to primary care, but it's maybe coming to the PCN DES and ARS, but nothing's coming to practices whatsoever. And even stuff that the digital monies has gone to commissioning support units rather than coming into practices. So there's a lot of concern. I think it's something like 3,500 GPs left last year, and I think, what was it? 1 in 5 practices closed since 2013. Sorry. and new GPs, they're leaving. 1 in 4 is leaving at the moment. Younger GPs plan to leave, and a lot of the GPs, a lot of doctors aren't planning to be in clinical practice. They're leaving to other sectors. So I mean that's an opportunity for other sectors, in that they've got some healthcare workforce for health tech companies, pharmaceutical companies. But it's a difficult time, challenging time, but that focuses people's investment and looking for solutions. So I think primary care is looking for more solutions, more and willing to explore the edges of reasonableness. So what I mean by that is the edges. So I think you have to explore the edges of what you can do, because we've got a contract and we can't over deliver that contract anymore. We have to really stick within our contract. We've seen workload coming from secondary care, which doesn't come with any resource to deliver it. And so there's been a big appetite to push back on that workload. But the opportunity is there in terms of new IT systems, new solutions. I'm looking at robotic processes quite often. I'm looking at AI triage type systems, anything that will help us be more productive, more efficient, and automate some of these repetitive tasks that don't need human intervention. So yeah, there's a lot of opportunities, and it is a difficult time, and I think there's going to be a massive
change, isn't there? There's a lot of change in primary care in the way.
Change in terms of the staff. The staff mix is very different than it was 10 years ago, and that's a benefit. That's a real big benefit. We've got bigger teams now, and I think that's really important.
Yeah. It's interesting. I know NHSE sent a letter out to all practices at the end of April talking about the fact there's been an additional 57.5 million appointments since pre-pandemic, which is huge. But obviously, with 3,500 GPs leaving, that's not GP appointments, is it? It's patient-facing appointments.
It's quite hard to, unless you really dig. The data is captured through GPAD, so it's GP activity data, and that, because a lot of work was previously hidden, it's hard to know what the increase is.
Okay. Oh, we've just lost you there, Neil.
Schedule activity that was a contact, but it wasn't a consultation. Yeah, sorry. Previously, we didn't schedule all activity, but now all activity is on there. So that some of it might be that there's better recording of the information.
Okay.
But yeah, like I say, it's a massive increase.
Yeah. So from your perspective, Jack, with the PCN DES, what's happening in primary care, the changing way that primary care is now operating, and the pressures that they're under, what sort of things are happening in your area or that you're aware of nationally to support primary care?
Yeah, it's quite a. It feels like a particularly unique ground, this one, because also I've been in the NHS as and have the experience of some of my colleagues, but every contracting round of it, no one's ever happy with the contracting round. I can't remember a time when anyone said, "Oh, yeah, this is a great contract. I can't remember it. I can't wait for it to come down." But this one was quite unique in that I had GP board members bring me up to I want to bring something to board this next month about how bad the GP contract is and how outraged the profession is and the impacts this is going to have, and we need to plan for the consequences of this through the year, and that was quite a step change of reaction to what we would normally see, even in a contracting round when people were quite dissatisfied. I think it is a changing landscape. Primary care. I think it is a. I think you have. It's the variability that makes it really challenging, because I have some of the most inspirational, top quality colleagues that I've ever worked with would be GPs who run excellent practices, but I could take a sample of any 50 practices and I'll see a threefold variation in any metric of your choice, a business metric, a quality metric, or whatever. And in some areas it's impossible to provide modern, good standard of healthcare if you're in a converted bungalow or a porter cabin in a park, and it's just you and no clinical backup or whatever, you simply can't provide modern healthcare like that anymore. So I think strategically in the next few years there will be a shift to greater collaboration. I think you will see smaller practices either giving up contracts or people choosing to retire who are single hands in practice, and therefore a natural sort of consolidation of the primary care market. And then I do think the partnership model I think is one that you're seeing less and less GPs choosing to be partners, and it's more and more difficult to recruit good partners. And I think newly qualified doctors want more portfolio careers across primary care. So I do think you will get to a point in the next sort of 10 years where there are more primary care organisations, whether they are limited companies or whether they are NHS trusts that develop a primary care arm. And there's a lot of models out there that do this very well and do this at a scale. And I think that will become more and more prevalent, and it will become more and more sort of an employed arm of the health service rather than the partnership model that we have. I think that's probably the 10-year sort of trajectory that you can see a little bit. And I know some of my GP colleagues would find that incredibly depressing. Others would see that as the natural next step. So I do think it's a really challenging time. I think the PCN contract and this sort of central, I think any time where you're forcing people to collaborate through a commercial lever, I think is never so it works in areas where people want to collaborate and they're a good mix of people and they get along quite well. But if you're in an area where you don't get on with the practices down the road and somebody's leveraged a contract over you that forces you to work together, that's not a recipe for high quality service delivery. So I don't like it as a principle. Is my personal view.
Okay. Yeah, that's just totally correct, Jack. It's that's really is what's happening, and I think what's going to happen further along is a private, like a two-tier system of private general practice staffed by GPs, and an NHS service that's GP supervised rather than being patient facing.
Yeah, I would also. Sorry, I was going to say I would also add to that, Neil. You're probably going to get other providers, for example, community pharmacy now looking at point of care testing. So co-creating with clinicians. So you've actually got a whole different kind of way of how people are delivering healthcare that may come about. However, I am rose tinted. I think there is something about what GPs bring, what primary care brings, that other parties can't bring to the table. And their ethos and their working and their hardship and their commitment, you're not going to get that at any kind of piecemeal kind of value. So whatever happens, it has to appreciate that once that is taken away, then what you will get will not be as good as what it used to be. And that's being really honest, because there's a huge amount of goodwill out there. I mean, I've got to declare, I've got friends and family who are doctors, I've got nurses in the family, I've got opticians. I get it. I've got people in admin, and it makes you appreciate the good amount of goodwill out there. And so if you try to build everything on a commercial model, which I know Jack was saying, you can't really force people to work together, and you lose that goodwill through either bad practice or actually not very good intentions. Once it's gone, it's really hard to replenish, and I think we've got to be really careful about that as well. So the workforce issue is really, really important. That has got, we've got to make sure that these people, and that's why everything that we try to do, we try to co-create. It's really important and powerful that decision making is there, and we're looking for opportunities, and we're being honest and transparent about doing that, because we want to hold on to the people that we've got. That's really important. So the heart of everything is the workforce. Without them, we can't deliver anything.
Yeah. We've got 2 minutes left. I'm going to throw one question out there that the audience have asked, and just ask for kind of a 1 or 2 line answer from each of you to see your views on it. So quite a few people have asked about funding. So obviously with ICS formation and consolidation of organisations and budgets, one question we had was, is there really just one budget? And what's being seen quite a lot is that what potentially should be happening with budgets flowing through the system into the right place or for the patient isn't necessarily happening. So kind of in 1 or 2 sentences for each of you, what are your views on that? Are you seeing the benefits and the difference with the way budgets should be working within ICSs? So Neil, come to you first. Have you noticed a difference?
No, I've not seen one budget. We have a very small budget, and I don't see how that the money doesn't follow a patient. It doesn't follow their condition. It is predetermined. That's all.
Okay.
My view.
Jack?
No. I've managed a health economy budget for a number of years. I've never seen it go in any direction other than become more fragmented and often decrease in value. And it's the fragmentation that kills it, to be honest, because you get a budget for mental health and you get a budget for this and a budget for that and a capital budget and actually it completely constrains your ability to plan strategically and use resource in totality. And so it's fragmentation that's a real challenge from a funding point of view.
Zafran?
So I have come across where, so the prescribing budget normally is not within scope anyway. The financial envelope is really tight. If you look at kind of cost of inflation, cost of medicines, that's always far higher than what they're giving you. You know, 2%, 3% growth, and actually you need a 10% growth to keep on line with that. Means that we're already, starting off the blocks well behind the first few runners. So it's a race that, you're always trying to play catch up. In terms of budgets and central procurement, that was quite interesting because there was this idea about making savings strategically and disseminating down to ICBs and then using that pots of money to then go out and test and trace and treat and prevent patients. Did that really work? I think it could have been done a lot better. So I think there is some degree of it can work, but then that resource needs to follow all the way through, and sometimes you don't see that. That's the problem.
No. Thank you. Perfect. So we're out of time, unfortunately, but thank you so much. So I'd really like to thank all of you for joining us and for the invaluable insights you've shared. So as we bring the webinar to a close, just remains for me to remind everybody that we're here to help should you wish to delve deeper into what the changes are and the challenges facing primary care mean for your business. So thank you once again for joining, and we look forward to seeing you at our next webinar. And please sign up to the newsletter and then you'll see what's coming next. Thank you for watching. If you'd like to find out more about our work with the NHS or how we could support your market access goals, please email info@mtechaccess.co.uk or visit our website at mtechaccess.co.uk.